Hello, everyone. Thank you for tuning into our podcast today. I'm Dr. Supriya Mannepalli, Medical Director for Infection Prevention and Control at Northeast Georgia Health System. I have Dr. Patel, Dr. Alix Schnibben, and Dr. Maria Munoz joining me today. And we're going to talk about urine culture diagnostic stewardship in the ambulatory setting. I think that's very important because majority of antibiotic use in humans actually happens in the outpatient setting. And UTI is one of the most common reasons why antibiotics, it's in the top 5 reasons why antibiotics are prescribed in the outpatient setting. And if we look at the data, honestly, we all kind of are aware of this, that antibiotics are overprescribed, but majority of what we call UTIs are not UTIs. They are asymptomatic bacteriuria or contaminated urine samples where antibiotic use is not prescribed or is not recommended. So again, I'll start with you, Dr. Munoz, and just brief introduction of what you do in the outpatient setting, your role, and then start with maybe share some common scenarios where urine cultures are obtained.
Okay.
Yeah.
Hi, so I'm Maria Munoz-Bramhall. I am a faculty at GME. I did my residency here. I graduated in 2024. And I do outpatient. I have my own clinic, and I teach the residents as well as inpatient. And yeah, it's very hard because especially if the patient is having maybe one symptom, just maybe a little bit of urine frequency, they're already calling it a UTI, even though there's no other symptoms. This is just my regular UTI problem. I just need antibiotics. Getting a urine, a U8 is important. And of course, if there is nitrites, there's leukocytes, then getting the culture is imperative to make sure that we are treating or killing the right bug. So educating the patient about that is important, but also educating them on how to obtain the urine. It's important because I feel like sometimes they don't even know how to do it. So I usually ask them, do you know how to obtain the urine? And they're like, oh yeah, just pee in the cup. And I'm like, no, you actually have to clean yourself and, from front to back and make sure you wash your hands, clean yourself, and then pee a little bit in the toilet and then collect the rest. And so that it's clean, don't touch anything inside. But it's important to get a urine culture whenever there is other systemic symptoms, like if I'm suspecting like pyelonephritis, complicated patients like who have diabetes, they're immunocompromised, or I'm thinking about kidney stone, or they have any urologic abnormalities. Anybody who's going to go for a urologic procedure, I tend to make sure that I get all of that. My pregnant ladies that come to the clinic that have any kind of symptoms, frequency, urgency, and I go from there.
Yeah, no, thank you for sharing that. I think you brought up a very important point about getting the clean catch being really clean, that midstream after cleaning. And I think we struggle with that a lot, especially with our elderly patients. Is there anything, Dr. Schnibben, as in your role as a quality director for NGPG, can you share something maybe we have done or maybe we can do in terms of really helping our patients be aware and also get their sample, because otherwise what we're just treating is dirty urines. Yeah,
we definitely don't want to be doing that. So I've been with NGPG as the Director of Clinical Quality and Ambulatory Pharmacy Services for 7 years now. Partnered a lot with Nancy Sosby. She's, does a lot with our labs with NGPG, and she's been doing a lot of great work around this. I think the signage in our bathrooms where the patients get the specimens from has been very good. It's very patient-first language. It actually has some pictures, especially in the OB offices when they open the drawers is where theirs is, and it actually has some pictures to show them exactly what we would like them to do. But I think she's took it a step further. Not only is it posted in our bathroom, she's really worked to educate the staff to give a verbal education, like Dr. Munoz was talking about, making sure that you actually tell the patient about it. But also the patients, like you said, the elderly population, sometimes they don't have transportation, so an adult child's going to come pick up the specimen cup. The document that goes with the specimen cup, really talks about the importance of, why we're doing this test, gives them step-by-step instructions for it. I think we could take it a step further by, having a QR code there that they could go to with all the pictures. We don't necessarily want to put the pictures out there and, small children open the bag and see. I think we've got a little bit more that we could do for the take-home education, but I think the education occurring at the site when persons can actually leave a specimen, has been done very well, but we can always do better, because you can tell sometimes when you get the cultures back that this is a purely contaminated urine and we need to stop the antibiotic. So I think using the culture results correctly is also important, but first you have to get the culture. And I think we missed that step. I think doing some more refluxing from the specimen to the culture is something we probably can educate our lab support staff within NGPG to understand when they need to do that or when they need to recommend it. So it's not like it is in the hospital where you've got some automatic things that occur. So I think there could be a little bit more from the quality component of the specimen, as well as ensuring that you have the result you need to make a good decision for the patient.
I think promoting UA with reflux culture, unless maybe they're pregnant, because we treat asymptomatic bacteria, or they have a urological procedure scheduled. I think those are the only two places where we would treat irrespective of the symptoms. But others, UA with reflux culture is the preferred way to test. And Dr. Patel, you practice in an urgent care setting. How common do you see patients presenting with UTI, true UTI?
I think we see that more commonly with the younger population, where they're actually true UTIs. But like you said, in the elderly population, there's so many other things that could be going on. But it presents as like a UTI type symptoms, like pain or burning cloudy urine. It doesn't always mean that it's a UTI.
Yes, I think that's kind of what we see, especially with our elderly patients. They usually have vaginal atrophy, change in the flora, the pH, and they have discomfort, dysuria, and that's usually the symptom they come with. Is that the patient, when you see that patient population and then they're being treated for recurrent UTIs when it's probably not a UTI, how do you educate them, and how do you manage those patients?
It's difficult because most of the time they are coming and expecting an antibiotic for their common UTI that they're been having, and they're prone to UTIs. That's what they tell me. Oh, this is just my other UTI, and then I always have UTIs. But understanding and actually doing a good physical exam, it's important, because sometimes it's just like you said, vaginal atrophy, and where I sometimes bring up vaginal estrogen. That can actually really help with lubrication, can help with the dysuria frequency, and can help with epithelial, So I tell them about it, and they're like, oh, nobody has brought that up. So it's always important to bring that up, and I'm like, try it and see if it helps, and most of the time it does help.
And now we have that endorsed in the guidelines also, and studies that have shown benefit where I don't know how many of them were true UTIs, but they show that decreased by 50% or more, depending on which study we're looking at. So we have good quality evidence now to support use of vaginal estrogen. Dr. Schnibben, can you share some other maybe symptomatic management modalities for these patients that don't have a UTI, but have some maybe discomfort or, just cramping, but not necessarily a UTI? What else can be done?
So, there's, multiple products to treat the pain, the things that turn you orange, your contacts orange, your tears orange, using products like that. But, don't want to use them for too long. So making sure that your patients are aware, the product over the counter, a lot of people are aware of the, the AZO standard. It's, I think, 99.7 milligrams. And then, a provider can give them up to 200 milligrams of a dose of that. So that's something you can do for like the pain. If, like you said, the analysis is not coming back showing a UTI until you can get, more information or get a urological consult, because, it could be, like Dr. Munoz said, it could be related to that anatomy and really needs a urologist involved from there. But there are other components for around, prevention as well, talking about, cranberry, people do a lot of cranberry juice or cranberry supplements, that seems to help with, acidifying the urine so the bacteria can't attach to the bladder wall. Some people like to do that. And there's, some other articles about some other, over-the-counter homeopathic remedies that can be do that have a good little bit of evidence in them. I think it's getting back to, educating the patient around, this is not a UTI, let's talk about the symptoms. But okay, if the pain is the big thing, you can try a couple of days of that, and then, stop it and let's see what it looks like.
But thank you for sharing that. I think one of the things we have done over the last few years, I think we really need to kind of share that with all the providers and publicize that, is the NGPG UTI algorithm, when to actually culture. Because when we get a culture when it's not indicated, even if it has a lot of WBC, that doesn't mean it's infection. Even if it has more than 10 power 5 colony forming units of bacteria, even if it's a drug resistant bacteria, that's not a UTI, which goes against kind of what we kind of, are taught of pyuria means it's not, it's UTI. It is not. More than 10 power 5. It's not necessarily a UTI. It could be just asymptomatic bacteriuria. Even if it's a drug-resistant bacteria, doesn't mean we have to treat because we do have patients where sometimes they're sent to the ED from outpatient because there is a ESBL or a CRE bacteria in the urine 10 power 5 and they come to the ED. They're waiting here for many hours. And then when they're seen, they would say they have no symptoms. And then when the provider says antibiotics are not indicated, then of course there is some discrepancy in what they have been told. And so I think it's important that as we are talking about ambulatory urine culture stewardship, we actually had a group of experts from ED, inpatient medicine, long-term care, and we did a podcast on stewardship on the inpatient long-term care side because it's all ties together and we all have to be working together on that. In the urgent care, when you see a patient, let's say coming that has a chronic Foley, and again, Foley catheter is equal to bacteria in the urine, not necessarily a UTI. But if truly coming in with the signs and symptoms of a UTI and we have to get culture, how is that obtained in the urgent care?
So that's a difficult one because our staff will get it from the Foley, but it's already bacteria in there. So it's going to be essentially not very helpful. That's a very difficult one because we are not allowed to recath the patients either. So we have to either just unfortunately treat them or use that as a specimen, as a culture.
I think that's something that's definitely an opportunity for us to follow up because the biofilm starts forming within hours and within days or there was a study they did, and I think within few days 100% of samples in patients with catheter had bacteria, even up to 10 power 5 colony units. So if we cannot change the catheter out, which is what we do in the hospital, unless there's a contraindication, like if we cannot touch that because urology placed it, they had a surgery by urology, we don't. But otherwise, if they have had it for 3 days or longer, we change it and get the sample with the new Foley in, if it's absolutely indicated. Otherwise, we don't even want to culture. But I think that's something definitely we can take that as a follow-up because if we cannot recath in the urgent care and collecting from the Foley.
We'll give the specimen cup to the patients a lot of times and just have them go home and drop it off when they're ready to. That's one option, but it's inconvenient for the patient.
I see. But if nobody's changing the catheter, they probably are just collecting it as well. From the same catheter that's been there for days, and hope not from the bag. That the urine sitting there for a long time. I think one of the things we have tried is to make sure that patients have 2 or more symptoms. If they have dysuria, then maybe there's suprapubic or flank pain instead of just one, because frequency can be from so many other causes. Dysuria can be from other causes. So looking for other, not just one, but more than one. That's why the algorithm is very helpful. When it comes to treatment, if it's the first episode of patient presenting with maybe cystitis, is it common practice to get a urinalysis with culture or just treat based on the symptoms for the first episode in a young, otherwise immunocompetent patient?
I would say it's pretty common to get urine analysis to make sure that that's what you're treating.
Well, that makes me happy as an provider, definitely. Because I know that some guidelines say if it's just first episode, no other urological history, that you can treat without a culture. But it's, at least as an ID provider, it's important to get that culture, get the urinalysis at least to see. Like, I think what helps is the negative pyuria. I think if there is absence of pyuria, which means there's no WBC increase, that has a very high negative predictive value that it is not UTI. The positive doesn't help. We have seen patients with hundreds of WBC and not a UTI, but the negative helps. I think when it comes to urinalysis also, I think interpretation of that can be tricky because they're not as sensitive or specific as we thought they were. So that's another challenge we have. When it comes to duration of treatment, what's the common duration that you use in the ambulatory setting for treating uncomplicated UTI?
They have not had any antibiotics recently. I usually just use macrobid 4 or 5 days, and that tends to really work for me.
Yeah.
That's what I've noticed.
Yeah, same.
Yeah, again, going back to the, that 5 for 5, it's so important that we're using shorter courses. Even in patients who get bacteremic with a UTI, now the recommendation is minimum 7 days. We used to do 14 days, but now the guidelines, the evidence supports use of just 7 days of antibiotics. And when it comes to the choice of antibiotics, Alix, we have worked on an evidence-based algorithm and evidence-based best practice for that. Do you want to share any?
Yeah, so we've been working diligently, and they're actually in revisions again because we just had new guidelines published by the FIDSA. So, it's continuously always starting with the macrobid. We've been very selective about cephalosporins that we want to use, listening to our providers at urgent care that, the 4 times a day is not as convenient. So can we look at it 2 times a day? So a lot more is about to come out about the use of, what's our other first line that we want to do as an organization, and then, our second line or third line therapy. So a lot more to come on that. But we are unifying what the hospital is doing well, so that the same treatment that would occur in the hospital or the ER would be the same thing what will occur in the ambulatory sector. So everybody's getting the same type of care.
That's good. Do you see use of quinolones commonly, or it's a rare thing?
Not as much as I used to before. No, that's not really anymore.
Yeah,
luckily.
We pull the data now. It's a lot more cephalosporins and a lot more macrobid.
Or Bactrim. Okay.
I don't see a lot of Bactrim. Resistant rates a little bit high
we
here.
Are higher here.
So we don't. A lot of our providers use that third line.
No, that's very good, because E. coli being the most common organism, I think locally looking at the local resistance rates is so important that I think thank you for bringing that up, Alix. That's very important that we look at our local antibiograms. One of the things we did years ago, we had to get a lot of approvals, but I'm proud of the work we have done, is suppressing quinolones for E. coli, especially in the urine. So it is out of sight, out of mind. So to promote alternatives like macrobid, the cephalosporins, but not, quinolones as really that last resort, absolutely, if we don't have any other options. So I think we touched on a lot of things, but I do want to mention some of the statistics as I was researching, I found ampicillin resistance for E. coli especially from 1960s to 2002, when they looked at it, had increased by almost 70%, which we see in our antibiograms. And again, and if we look at in 2016, they published some data, again almost 10 years old, but 3.7 million office visits and 2.6 million ED visits in US just for UTI. And there was a study kind of led by CDC researchers where they looked at more than 4 million encounters, and 82% of the patients got an antibiotic. So again, a big area for us to work on with ambulatory stewardship, not getting urine cultures when not indicated, and treating for the right duration with the right antibiotic based on your local antibiogram. Altered mental status, elderly patients. We cannot end discussion on this without touching on that. When you have a family member coming in with an elderly patient, they say that is more lethargic, is not eating well, maybe a little bit confused. How do you approach that? And they want you to test the urine.
It is very hard because most of the time they have had a UTI in the past, and that these are some of the symptoms, and they will say, hey, mom is having that UTI again. Can we just get an antibiotic so that she can get better? And educating them, and that, altered mental status could be a lot of different things, unfortunately, not just a UTI. So getting, unfortunately, a UA, I will need to get one to make sure that is what I'm treating. And I educate them that I may miss something else, something else that could be worsening, maybe needs to go to the emergency room for treatment, and I don't want to miss that.
Do you see that in the urgent care setting?
We see that a lot. Yes, alternative status usually ends up in the urgent care. And then we have to deem if they need to go to the ER or not. And it's usually, it's surprising. Like everyone usually thinks that, it's a UTI, but I was like, what if it is something else? It's what if it's a pneumonia? What if it's something else? And a lot of times the elderly patients' history is not. They're not that great historians sometimes. So then it's also a little bit difficult to delineate, do you have symptoms? And they're not able to tell you. Yeah. So then you do end up doing a UA. And unfortunately, I do the culture with it sometimes, and then sometimes they're contaminated.
Yeah.
So it becomes so very hard. And you're trying to keep them out of the ER because, if you can, because then that's just going to worsen their mentation. Their eating is going to get worse. They're going to maybe get hospitalized and then maybe nothing came of it. And it's a very difficult, it's a very difficult situation.
Yes. Yeah. And I think this is one where even now we have the guideline support that if it's just altered mental status alone or lethargy with no specific urinary symptoms, that look for other causes before we test the urine. I think that's most important. Had at least 2 scenarios recently shared by providers. One was a patient who had a CVA actually, but then was being treated as a UTI. And 2 was somebody whose Lasix dose was changed and was dehydrated and lethargic, and again was treated as a UTI because the urine was abnormal because it was not a true clean catch. And again, they received antibiotics were not indicated and developed this drug-resistant organism, C. diff. Had a scenario like that where we had patient with 4 or 5 episodes where received antibiotics and then came in with C. diff. Yeah, so we do see those. And so I think that is definitely a difficult clinical scenario, but again, continuing to work through educating the family members and looking for other causes is very important. Chronic suppressive antibiotics, do you guys get requests for those?
I don't get requests for them in the urgent care because if they're chronic medications, we typically don't, go in that realm, but we do get patients that are on them and then they are coming in with, they're taking their antibiotics, but then they still have these symptoms, or they're coming in with new symptoms. I had a UTI now. And then that, that's definitely there,
Because for me, sometimes they do ask about it, but educating them that it's not good practice. Side effects are, benefits versus the risk. I always tell them, and the risk of being on antibiotics chronically, it's not good because of all the side effects that can cause them. So most of the time they're actually open to not having antibiotics chronically. They understand the side effects, so I don't get as much anymore because they're gonna know what I usually say. But I have seen them. I have seen some of them, and it's just very hard to get them off of it. Oh no, this is the only thing that has worked for years, and this is what I get.
And I think that's the thing when we used to get a lot of referrals too for ID, for chronic antibiotics, suppressive antibiotics for recurrent UTI, and either they're already on Bactrim or Macrobid, or they want us to start one of them. And the side effects, one of the side effects of Macrobid, it used to be a board question, maybe not anymore. Chronic use can lead to lung disease like fibrosis, interstitial lung disease, and Bactrim comes with a lot of side effects, and already we are seeing increasing resistance in our community to the common pathogens that cause UTI, and quinolones come with so many side effects. So, and the benefit, bugs are smart, they become resistant. So I think it's really not a recommended practice. Dr. Schnibben, we recently have seen this PCR testing in certain offices where urine is not sterile, it's a molecular test, and it gives us a list of different organisms with resistance that can you share more about that?
Yeah, so there is a urine PCR test. We definitely have worked with our hospital-based pathologist and our hospital lab to kind of validate those. And what we found is it's not good practice. It's screening for so many bacteria, and some of them not even going to be found in the urine. And then it also screens for every single antibiotic under the sun for resistance to that to that bacteria. and the patient may not even have a urinary tract infection. So what we have found is not only are they not specific and not sensitive enough to meet the expectations of our organization, we also saw the use of them leading to a higher usage of antibiotics in patients that we should not use them in.
Absolutely. I don't think we know enough about these tests, and urine is not sterile. So to use a test that can, that is so sensitive, that is picking up this molecular material, nuclear material of these organisms, at this point, we don't know enough to really recommend them, but there is harm definitely by using those tests. The Long-Term Care Society did put out a statement, but I'm hoping that IDSA and others do also have some position statements on that, because using them can cause more harm than help. I think we touched on most of the common things. Any last comments from? Okay, no, I think
it's just important to know that the culture is there. It's a tool, but urine has to be corrected correctly. You have to use the culture on the correct person, but don't do a urinalysis on everybody.
Yes, do not do that.
The appropriate population.
I actually had a young girl who came in, fevers, flank pain, suprapubic pain, all of the three, but didn't want to go to the ED or hospital. So we said, okay, let me try to at least get some tests done in the office. She didn't want any imaging done as well. So we said, okay, let's get the urine, some labs, CBC, put her on some antibiotic pending the cultures, because I was concerned about pyelo. Hope she's not bacteremic, but she definitely didn't want to go to the hospital. She was having nausea, vomiting. So we're trying to do what we can in the outpatient. Get the UA, they were like 10, 15, definitely more than 10 WBC, but it didn't reflect to culture because it has squamous epithelial cells. That's our criteria here. We updated our criteria where if it's contaminated with epithelial cells, we don't culture. The next day when we follow up, we had no culture. She was still symptomatic and didn't want to go to the hospital yet. But this time was okay with getting imaging. So we ordered a stat imaging and also another repeat urine, this time again with repeated instructions to get a good sample. And UA was negative. She had a ruptured ovarian cyst.
Oh. Wow.
So again, there's so many causes that I think UTI is something we jump on. So looking for other causes, that alternate mental status is not always from UTI. Look for other causes before we look for UTI. Any last comments?
No, just that it is a good test to have in clinic especially, but making sure that we are testing the right population and we are actually looking at the differential, making sure that we look at each patient individually and not just criteria to make sure that this is a UTI, just give antibiotic and let them go. So making sure we're taking a good history and educating them on how to get the UA, it's important.
Yes, it was. No, again, thank you so much for joining me today in this discussion. This is another one where we have to continue to educate our providers and community.
Yes.
Yeah. Thank you.
Thank you.
Thank you.